Good afternoon, everyone, and welcome to the COVID-19 2.0 Health Literacy Echo for Medical Providers, brought to you by Health Confianza, a collaboration between the UT Health San Antonio and the San Antonio Metropolitan Health District. Thank you very much for making this time your priority and joining us in our session today. And I hope you and your family doing well. I would like to mention that we are recording these sessions and we can share it later. Please know that anything listed in the chat will be seen in the recording. My name is Raquel Romero. I'm a physician by training, and I'm going to be the echo facilitator for the session today. We have a lot of information to cover, but before we begin, I would like to ask our UT Echo IT person to provide some directions for us. Carly.
Hi, please stay muted unless you're speaking. Please, you can use *6 on your phone if you call in, or the microphone icon on the bottom left of your screen if you join on a computer. You can also communicate with the chat feature. Please remember that no personal health information will be allowed during the scenarios and cases. If you are having issues with your connection, you can privately chat UT Echo IT. Thank you.
Thank you very much for these instructions, Carly. Yes, additionally, please remember that if you have some issues with the connection, some problems, you can add your comments in the chat box, or you can send a private message to the UT Echo IT. And I invite you and encourage you to add your comments, your perspectives, your questions, and suggestions in the chat box. We will try to address them through the session today. You can also reach out to us after this session by email. We promote interaction in our sessions, and we would love to see everyone's faces. And if you're able and comfortable, I invite you to join us by video, especially in the discussion part of this session. And please remember that no personal health information is allowed within discussing cases and scenarios. I would like to mention that these sessions are open to everyone, and once you register for this session, you automatically will be registered for the complete series. And we're excited to announce that Health Confianza has special items to acknowledge your time and your dedication to these sessions, and there are two types of awards. If you attend 5 or more of these sessions, you will get a pin with a Confianza logo. If you attend 8 or more sessions, you complete our baseline and post-session surveys, you will get a pin with a Confianza logo and a certificate as a health literacy champion, and public recognition for you and your practice site on the Confianza website. So please try to attend our following sessions. I promise that will be very, very informative. I would like to continue with introductions. For our participants, and I would like to ask you if you please add your name, your title, your contact information, and the organization that you represent in our chat box. This is for our attendance records. We would like to know who is attending our sessions. Health Confianza is a county-wide collaboration to improve access to and uses of the COVID-19 health information and service in Bejar County. With that, and before we get started, I would like to use this space to introduce our COVID-19 health literacy ECHO team, and I would like to start with Dr. Berggren, lead specialist, moderator, and didactics speaker in the session today.
Hi, thank you so much for that introduction. My name is Dr. Ruth Berggren. I'm a professor of medicine and an infectious disease specialist. I'm a very proud member of the Health Confianza team, and it has been my privilege to organize this Health Confianza COVID-19 Health Literacy Echo for Providers version 2.0. There's still a lot to talk about and a lot of ways that we can help our community. So thank you all for being here.
Thank you very much, Dr. Berggren. And we have Dr. Stone, a panelist today.
Hey everybody, I'm Melanie Stone. I'm with UT Health San Antonio, where I direct our community service learning program through our Center for Medical Humanities and Ethics. I am also serving as co-investigator on our Health Confianza initiative. I'm leading out our organizational health literacy pledge program, and I'm happy to join you all today to talk about my favorite topic, health literacy.
Thank you very much. I have Dr. Case, panelist.
Hi all, my name is Kitty Case. I'm an assistant professor at UT Health San Antonio with a focus on health communication, among other things, and I look forward to hearing from today's speaker. Thanks, everyone.
Thank you very much. And I have Dr. Rosenfeld, panelists today.
Hi, good afternoon, everyone. Jason Rosenfeld, Assistant Professor in the Department of Medicine and Implementing Director of the Health Confianza Chain. It's great to be with you all this afternoon.
Thank you very much, Case presenter and panelist Joaquin Abrego Muerte.
Good morning, y'all. Joaquin Muerte, Community Outreach Coordinator. I am with the Health Confianza and the Office of CHME, and a community organizer and social justice activist.
Thank you very much for joining. And also I would like to say thanks to you all to be with us today, as well as for our ECHO team. ECHO stands for Extension for Community Healthcare Outcomes. It is a model that provides learning, opportunity, and telementorship. The goal is to bring the knowledge when it's needed, where it's needed, to build community capacity for delivering best practices. The core components are the didactics, the case-based discussion, and a conversation, dynamic conversation. The case discussion is an important component of the ECHO model. We invite you to submit clinical and non-clinical cases for be presented in our sessions. And for those that already present a case, I would like to invite you to consider presenting a follow-up. We would like to see this as a learning opportunity and sharing your experience while taking care of the patients. ECHO IT will share the instructions on how to submit those cases in the chat. And please check our website if you want to know more about the ECHO model and other programs that we have. These sessions are possible because of you, because of your feedback and it's so important for us. I would like to ask you if you please complete the survey that you receive when you register. Towards the end of the session, you also will receive another survey. We would like to hear from you. ECHO offers the CME, CNE, and Ethics Continuing Medical Education. And to obtain those credits, the information is in the chat. The activity code is 1009169. As part of our agenda, next we have didactics, and then the case discussion. Finally, I would like to mention that ECHO is all teach or learn environment. So we encourage to share your experience and questions and insights our conversation today. With no more from my end, Dr. Berggren, this is your space, please. You are muted, Dr. Berggren. Thank you so much.
Got it, unmuted. And I think my hub team member is going to help me by bringing up the first slide from my didactic session today. While she's doing that, I think it's Carly, right? Carly's bringing up my slides. I want to let everybody know that we have some special incentives for this 2.0 iteration. People who attend 5 or more of our sessions will get a special lapel pin that says Health Confianza. But people who attend 80% or more, which is 8 or more sessions, not only get the lapel pin, if you also fill out our surveys, which are really important for our process improvement, and you submit one case, then you get the lapel pin, you get a special certificate signed by us that you are a Health Confianza health literacy champion. You get public recognition on our website and recognition for your healthcare practice site, touting your site as one which is especially attuned to the importance of health literacy and clear communication. So hope some of you will take advantage of those fun incentives and soon be the proud owners of your Health Confianza lapel pins. So this is the second session of this iteration, and it's really the intro session. And let me explain that. We launched 2 weeks ago with Dr. Mandy Svatek, pediatrician extraordinaire, because we felt that in light of school starting up again, that it was really important for everybody to hear from a pediatrician who's very skilled at health communications, especially with respect to vaccine. So that's why we just jumped right in to our session on pediatric vaccines without pausing for a minute and say, what the heck is health literacy? Why are we talking about it? And why does that underlie all of these COVID-19 healthcare provider echo sessions that we're doing? So it turns out that health literacy is a pretty critical tool that will allow us to promote health equity, not only in the context of COVID-19, that's a little bit of the excuse for why we have this session now, but health literacy helps us promote health equity very powerfully across the board. Next slide. This is just the reminder code and a required disclosure slide. I personally have no financial conflicts of interest to disclose, but you should be aware that we do have funding for this program from the Office of Minority Health and the Department of Health and Human Services. And you can find out more information about that by visiting the website shown on this slide. I want to cite Martin Luther King in this context. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. We believe in that very deeply, and so it is a privilege and an honor to engage in the work that we're here to do today. What I hope to do is compare and contrast the most recent definition of personal and organizational health literacy. What is health literacy? How do we define it on a personal or an organizational level? We'll look a little bit at some examples of the very important link between low health literacy and poor health, including COVID-19 outcomes in our city. We'll look at health equity promoting tools within the layers of our health systems of care. And finally, the ultimate goal that will begin today is to enhance our proficiency in practicing the first of 6 health communication skills, which is using plain language. We'll talk about all 6 of them. And I'll talk about how when we think about COVID-19 Health Literacy 2.0, we need to take those as our base and go beyond to another set of skills that we can help each other with. Next slide. So let's remind ourselves of the context in which we find ourselves. We are in a community where we are the quote-unquote majority-minority city. 64.5% of San Antonians identify as Hispanic, which is not at all surprising considering our history. And we have 17.8% that are living below the poverty level. We have almost 20% uninsured. Over 250,000 of our residents here do not have health insurance. So becoming ill is a very big burden, not only for the person who's sick, but also for everybody around them. 1/4 of the patients who come to see us at University Health System are unfunded. About 23% require assistance by interpreters or translators. We have a 14.3% foreign-born population. Over 1/3 of our immigrant population that we take care of here is undocumented, presenting additional challenges to their care. And there are a couple more bullet points if you keep clicking. We have, in addition to our core residents, we have a lot of new people coming in all the time. And we had resettled over 10,000 international refugees since 2010. But the volume of migrants coming through our city, whether they decide to stay and resettle here or just go on through, that volume is increasing rather dramatically. So from a news article just this year, by mid-year, the city was expected to see 19,000 migrants traveling through our city legally just in 1 month. So we may have up to 20,000 people traversing our city. Sometimes they get sick and sometimes they get stuck here because of health-related issues. And these are important members of the community that we as healthcare providers need to be thinking about and need to be addressing. So all of these facts about our city and our location have implications for health outcomes and therefore for interventions, and health literacy is one of them. Next slide. So let's start with that definition. And these are the most recent definitions for health literacy on an individual, and then we'll do the institutional level. So for individuals, the definition of health literacy is the degree to which individuals can find, understand, and use information on the one hand, but services also, which inform health-related decisions and actions for themselves and others. This comes from the U.S. Healthy People 2030 initiative. Next slide. We'll look at the institutional, can you go back one? There we go. Institutional health literacy is described as the degree to which organizations, such as the ones that we work in, the places where we practice, the places where we see patients, the degree to which organizations equitably enable individuals to find, understand, and use information as well as services which inform health-related decisions and actions for themselves and others. So there are implications for individuals as well as organizations. Next slide. And so what are the important aspects of these definitions? Why do we dwell on them? I think it's worth noting that they emphasize people's ability to use health information rather than just be passive recipients of it, that there's information that they're supposed to understand. They're supposed to understand it and use it. There's this focus on people's ability to make well-informed decisions rather than appropriate ones. And that's an important distinction because we're always trying to communicate in a non-judgmental fashion. It's not up to us to say what's appropriate, but we can certainly make sure that people are well informed as they take charge and make their own decisions. They emphasize the wellness of the individual making a decision as well as others. So in that way, they incorporate a public health perspective. It's not only about health of individuals, it's about the health of a community. They acknowledge that organizations have a responsibility to address health literacy, which is maybe something that's been under-focused on heretofore. And finally, these definitions indicate that people and organizations can use their health literacy skills to improve the health of our community and its members so everyone can flourish. Thank you. And the next slide. So, if you joined us last time, you would have seen this slide before, but it's worth reminding ourselves about it because how often we forget. Nearly 9 out of 10 adults in the United States have difficulty using everyday health information. This is just across the board from a national assessment of adult health literacy from almost 10 years ago. It's not even zeroing in on a community with the specific demographics and language particularities that we have here in San Antonio. So somebody who's proficient in using health information would be an individual who's capable of calculating their own share of their health insurance cost if they're employed and they have their health insurance through their employer. That challenges me sometimes, I think. So the bar for proficiency is pretty high. But if you look at basic health literacy means you can answer simple questions based on a clearly written health pamphlet. Interesting that only 22% are able to do that. And so if you look at basic and below basic is circling the date of a medical appointment from a handout. About 36% of our adults have basic or below basic health literacy skills. What does this mean? Next slide. Well, it correlates with health outcomes. And there are many studies, we won't review them all here because there's no time, but a sampling of studies with the big picture outcomes that I have put in the boxes tell us that folks with low health literacy are more likely to need to go to the hospital. They're more likely to have chronic health issues or poor control of their chronic health issues. They're less likely to seek treatment because they haven't integrated their awareness about their health into their priorities. And many of them are on a day-to-day survival or subsistence level. Low health literacy also costs us money. It has been estimated to have added up to $238 billion of unnecessary costs to our already overburdened and very expensive healthcare system. So there's some references about why I'm making these claims. They do come from peer-reviewed medical literature. Next slide. So let's zero in on one specific example. Let's make this more specific and less general. This is a study looking at glycemic control for diabetics, and we use the indicator of the hemoglobin A1C to determine how well controlled somebody's diabetes is. And here we're looking at, in the A panel, people that have a hemoglobin A1C less than 8%, which would mean they have reasonable control or some evidence of control. And in panel B, we're looking at people that have hemoglobin A1C greater than 9%. This was done in a practice where there was a known correlation or lack thereof of the language that the physician spoke and the language that the patient spoke. And so LD means language discordant. LC means language concordant. And so in a particular practice where all of the patients' language was known, their provider's language was known, and their hemoglobin A1C was known, we looked at what percentage of patients had good control or bad control, and compared them by whether they were with a physician who had the same language or was language discordant. So, and a switch was made as they made an effort to get people better matched. So there's a better language match between the patient's language and their provider's language. So important takeaway points, look at panel A, that's looking at people with good hemoglobin A1C. If you're language discordant, you have that low gray bar, about 60% of the people had achieved that kind of hemoglobin A1C control, but then they switched so that the patient and the provider had concordance, and you can see a significant rise in the proportion of patients. Almost 75% now had better hemoglobin A1C control. And looking at sort of the flip question, people who had poor control, greater than 9%, there were a lot of them, right, before the switch, when you had a language discordant situation. Then when they switched to a language concordance between the patient and the doctor, you had a reduction in the percentage of people that had a poor hemoglobin A1C. So this is just one study. I don't want to overemphasize it, but it shows you that these sorts of things really can be studied, and something as very simple as whether the patient and the doctor or the nurse practitioner or the healthcare provider are speaking the same language has a health impact. And we can take that literally, and we can also take it metaphorically, because when we talk about speaking the same language, we also refer to understanding one another's perspectives, right? Next slide. So all of this is going on within a very complex environment. This is just a reminder that individuals have characteristics that they can't change about themselves, and those characteristics will influence their health outcomes. So we're not able to change our age, the sex we were assigned at birth, and other constitutional factors that make up who we are based on our genetics. But then we make choices about individual lifestyle factors. Those aren't always made out of free will. Those are very much directed by the society and the community networks in which we find ourselves, behavioral norms, what's acceptable, what's not acceptable. That in turn is affected by what's possible in the environment. And our environment is affected by things like agriculture, living in working conditions, water, sanitation, and hygiene conditions. And what a small little box that is over there on the right, healthcare services. We tend to think that health of a community is all about those healthcare services. In fact, what we do there in that box when we go to work every day is a small but important piece of all of these factors that are influencing the health of the individual. And then we can expand the concentric circle even another layer to talk about the general socioeconomic, cultural, environmental conditions that exist in our state, in our nation, and in our continent. Next slide. So that was one way of looking at the layers that an individual finds themselves in. Now, if we narrow our telescope down and look at specifically people as patients, not just individuals, a patient exists surrounded by a team of healthcare providers, the frontline providers, with other professionals and family members, all of whom interact with one another in the context of organizations like hospitals and clinics, which themselves find themselves in an environment which is affected by regulatory and market factors, as well as policy frameworks. So this is a multi-level system in which individuals are needing to find access and use health information and services to make healthy decisions for themselves and others. Next slide. So our goal is within these complex systems to see if we can have the best possible outcome related to health for all people. And we do like this slide because it shows different heights of people that are all reaching for an apple, which is our health metaphor. And we see that if we give everybody the same size block to stand on and say, well, do your best, there are going to be some people who are just not going to reach the apple. And there's some people who will require more input from us in order to attain the maximum available health status that is possible for them. And so achieving equity requires that we understand the root cause of the disparate health outcomes that we have in our community. And remember that equality does not equal equity in terms of outcome. Next slide. So here's a snapshot of COVID-19 surveillance and COVID impact in Bexar County from early in the pandemic, with darker meaning greater impact. People have seen maps like this before, but the places where COVID was hitting the hardest and causing the most disease and the sickest patients happened in historically disadvantaged parts of our community. And we saw predominantly south, east, and west San Antonio, places that have been historically redlined, places where there are historically higher rates of diabetes, higher rates of diabetic amputations, also showing disproportionate impact of COVID-19. Next slide. And so given that, our partners at Metro Health and UTSA came together with our health literacy experts at the Center for Medical Humanities and Ethics and came up with a strategy to target these 22 high-impact zip codes in San Antonio for a health literacy intervention, with the idea that if we advance health literacy, maybe we can enhance more equitable health outcomes related to COVID-19. So that's the HHS grant that is permitting us to have these wonderful echo sessions and many other programs that are affiliated. Next slide. You can see it's about 600,000 people that are being targeted by our efforts. And with this funding, we're working hard to develop and disseminate information about preventing and mitigating the negative consequences of COVID-19 and trying to do so in a way that engenders trust, because we provide accurate, accessible, and actionable information. We're promoting and facilitating changes, not just for individuals, but within the Bexar County health and social care system. So we're targeting organizational health literacy, for instance, with leadership programs and special training. And we're trying to support and expand efforts to provide culturally and linguistically appropriate COVID-19 health information and services. Notice this is all COVID-19 related, but as we think about it, if we do this well and set systems in place to do it well, these efforts will impact many other health issues, because rising tide floats all boats. Next slide. And this is the convergence strategy that is a helpful conceptualization for how we believe that everything that we're doing is going to work together for the same desired outcome. Communication training at the organizational level, the interpersonal level, and individual patient education will impact both patient motivation and clinician motivation, enhance communication, and then enhance patient engagement for better decision making. Obviously, we're interested in vaccination uptake as one of the outcomes, but also more reduced morbidity and mortality for people in these targeted zip codes. Next slide. Examples of how we've been out there as a team promoting messages that are health literate in their characteristics. There's Dr. Jason Rosenfeld and Mia Vento, Health Confianza team members, and Dr. Rosenfeld, the leader of our Health Confianza team, pointing to 5 key messages about COVID-19 vaccines in Spanish. They're at a church in a largely Spanish speaking neighborhood. And these messages are written in such a way as to embody health literate principles. So we're using plain language. You can help stop the pandemic by getting the COVID vaccine. The COVID-19 vaccines are safe and effective. We certainly know that's evolved. They're effective at preventing you from getting so sick you need to go to the hospital and so sick that you die. We all know that with the variants, the COVID-19 vaccines will still let you get COVID, but you won't get as sick as you would have if you hadn't been vaccinated. The vaccines themselves are not costing us money, although the cost of administration might go to our insurance companies if we have insurance. The vaccines do have side effects. We acknowledge those, but those are normal signs that your body's building protection. And for maximum protection, it's still true that masking and hand washing are helpful in reducing risk, even for people who have gotten vaccinated. Next slide. So here are the 6 communication skills we talked about last time, and these are our reading, writing, and arithmetic. These are the core and the base on which we need to build for COVID-19 communications 2.0. But they start with setting the tone, and always we want to project a very respectful tone for whoever it is we are speaking with, unconditional high regard. We want to demonstrate active listening so that we're not responding inappropriately to concerns that a patient may be bringing up. Using plain language or using the right language, as I've gone through just now. It's important to acknowledge different perspectives, even if the perspective that a patient is bringing is based in scientific misinformation or disinformation. It's important to, instead of dismissing or batting that away, to acknowledge that someone may have heard those things, or I have heard those things too. And then we bridge respectfully and creatively from that different perspective with which we do not have to agree, even if we know that it's false. We acknowledge it, we don't agree with it, but we bridge respectfully to the fact that we do want people to remember. And finally, using the teach back method to check for patients' understanding. And I have to discipline myself, even as a health literacy champion, to take the time to ask my patient to repeat back to me what they've understood, to check myself as to see how effective I've been as a communicator. These 6 core communication skills seem obvious to us when we put them all out there. But what's challenging is to be mindful and to keep them in our awareness always as we're communicating with patients, and especially when we're talking about something that may be fraught or difficult to get across. Next slide. Using plain language, I like this cartoon because it's a great meme almost. Instead of saying cellulitis, why not just say skin infection, and then the message gets through the first time and you don't have to reiterate. It saves time, it's respectful, it doesn't waste a lot of cognitive bandwidth of the patient who's then wondering, why am I not understanding what my provider is saying, and empowers everybody to act and act quickly for the health of the patient. Next slide. We're not going to unpack each of the 6 because that will happen in the course of our entire ECHO series. But here's kind of the 2.0 part. We've learned after 2.5 years of dealing with COVID that vaccine decision-making depends on more than just using plain language. This is the 2.0 part. And so I want to draw your attention to a nice little study that got published recently in the Journal of the American Medical Association called COVID-19 Vaccine Decision-Making Factors in Racial and Ethnic Minority Communities. This happens to have been done in Los Angeles, but it's relevant for us in San Antonio. The investigators asked the question, what factors do members of multi-ethnic communities who are at high risk for COVID infection and bad outcomes from COVID, what do they cite as influencing their vaccine decision-making? And it turns out there are a number of processes. I've got 6 of them bulleted here. The decision-making gets influenced by misinformation, and the misinformation is coming from a lot of sources. It's coming from peers, it's coming from the internet, social media, and other forms of media like television and radio. It is influenced by politics. It is influenced by people's apprehension and real fear that comes from historical inequity and mistreatment. It's influenced by barriers to healthcare access that are related to social disadvantage. When we first had our vaccinations at these huge hubs, a lot of people would have to take the bus or need transportation to get there. Something that simple presented an access barrier. We had to get the vaccines out into little neighborhoods so people could really get their vaccines. There is a need for community engagement, and there's a need for trusted messengers. These are 6 key points that came out of that study from Los Angeles, highly relevant for us today. Next slide. So the need for the trusted messenger is the bullet that I kind of landed on, because that is who we can be. We can be the trusted messenger, but we need to think a little bit more deeply. Are the trusted messengers in our community, are they just people that are in white coats? Are they just people that are able to write prescriptions? Or who else are they? And how do we work together as a team? You know, there's been a lot of confusion around masking messages in COVID-19, even from the highest authorities in the land. Even the CDC confused us in the way they gave the messages. So that undermined the trust that people have in health organizations that previously were trusted. Then there were things that happened, like the variants emerged a lot faster than expected. The COVID-19 variants began to escape the protection that was promised by the vaccines, and people began to lose trust in that. And then some people actually did have some frightening side effects. Overall, the vaccines are safe. There are some subgroups that have specific things that they need to watch out for, such as heart muscle inflammation in adolescent boys who get the mRNA vaccine, or the blood clots that appeared in some women of reproductive age when the Johnson & Johnson vaccine was given to those groups. So these things happened. And in an environment of mistrust, they got amplified. And both the internet and a lot of politicians, to their own ends, amplified people's fears through both misinformation and disinformation. So COVID-19 Communication 2.0 regards really figuring out who are the trusted messenger, who can still be a trusted messenger. How is that true specifically in San Antonio? And I would argue that the trusted messengers really are us, but as a team. And we need to think about everybody from the person who's facing the patient in the waiting room, to the person who's writing the prescription, to the person who may be accompanying that patient and the family member. Next slide. So let's skip past this one. Next slide. We have a new thing that we do now, which is to make sure that halfway through our session, for people who might have logged in late, that we have one slide that hits on those key takeaways. If you got nothing else from this talk, what would it be that we want you to take away? And that's a reminder of the base on which we're building COVID 2.0. The base is these 6 communication skills of setting the tone, active listening, using plain language, acknowledging different perspectives, bridging respectfully, and using the teach back method to check for understanding. Next slide. So I think, and I'd like to hear from you as well, in communicating COVID 2.0, we need to depoliticize both the messenger and the message. We need to think about the fact that people are sick of talking about COVID, and maybe expand beyond COVID, because these principles apply also to other new things that are coming down the pike, like monkeypox, like the fact that polio is making a comeback, and there was a paralysis case in New York not too long ago. People are concerned about their general wellness, and mental health is critically important. I don't need to tell this crowd that. So in communicating COVID 2.0, we need to be willing to expand and talk to people about what's most on their mind. And that may mean coming in with a different topic or under different banner. We do need to find creative ways to continue correcting misinformation as well as disinformation. We need to develop barrier-busting strategies like we've tried. Mobile clinics for vaccination, still being asked to do that. Town halls where small groups of people go talk to small groups of people and meet face-to-face, so it's not all on television or on the internet. People need to accompany one another. And that can be community health workers accompanying patients, for instance. And we need to engage the communities, our communities, via the most trusted messengers. And what we've seen is that includes faith leaders. It includes outreach workers and community health workers, promotoras. It includes school nurses who need a lot of attention from us now because they're coming under scrutiny and under tremendous pressure, especially right now when school is starting up again and they're exhausted. And then family members. Sometimes we may not be able to get to the person that most needs to hear the vaccine message as a healthcare provider, but maybe we can get to them circuitously by influencing their family members. And we have a case today that might illustrate that. And so Health Confianza champions. We are they, and you all can become one. I invite you to stay with us, continue to attend, and visit our website at www.healthconfianza.org. Now, I also got a message that I've gone a little bit over today in my enthusiasm of getting everybody revved up for 2.0. And so let's move now straight to the case. And I'm going to ask for the case to be brought up, and I'm going to ask Joaquin Abrego, our community health worker and outreach coordinator, to go straight to that case. It's something that he heard in the community and kind of was a witness to, and it has implications for us and for our discussion. Joaquin?
Hi. Okay. So the case was from a community space that I was visiting as a member of Health Confianza. I was at a community event, and a lot of times whenever I'm at community events, I am kind of just intermingling and talking with folks. If we do have a table set up, I usually just kind of like walk away from my table and jump around with a bunch of people introducing myself. I was in a huddle or with a circle of men. And one of the guys had mentioned to me about their recent experience with COVID, as I was kind of talking about like my own personal experience with COVID. And one of the men they said that he, well, the conversation was kind of like, I didn't have a choice. I had to go to work. I had COVID. I felt like I was getting sick, and I know that I had gotten it from one of the kids. So when he got to work, he worked in a camp with a group of mechanics. He basically said that when they got to the camp, he told people, "I'm not feeling well, but I can't take the time off. None of us can take the time off. So I'm just gonna work." And so as the days continued, each one of the team members began to feel sick. They all kept in the field. They all continued to work in the field because they were kind of pushing each other to kind of, they were kind of telling each other, like in a way, like in slang, not to be lazy, not to let the COVID be a weakness, and don't be weak about the situation. And also they were telling each other to keep quiet about about being sick because they couldn't afford the time off. And so one of the members of the team had got so sick that they had diarrhea and vomiting, and so then he kind of mentioned that he couldn't go back to work, that he was going to kind of stay at a day in the camp, not going out to the field. And they said, well, keep it to yourself. A lot of it, the biggest reason that they decided to keep it to themselves is because the company policy doesn't pay them for COVID time off, and would dip into their vacation times, and so they won't be able to have family. They won't be able to take vacation with their families when it's needed, like Christmas or summer, or certain days where kids, their kids are at school and they have parent school stuff. And so that was kind of one of the biggest reasons that they decided to just rough it out. And the majority of them had big symptoms. It was like all the symptoms of fever and cough and we call cold sweats and and diarrhea. What is it called? Sore throats and body aches. Whenever I talked to them about it, I let them know that they needed to they needed to be careful with each other, but a lot of them were kind of asking like, what have you done? And so I guess that's where I'm reaching out to you guys about this. How can we make these changes within the company? What are the ways that we can maybe make changes or have them change policy around giving them time for COVID wellness or COVID leave, or even just having sick leave, a better sick leave. One of the things too was, given that some people feel they must work even when they're, so what are some things that we can suggest to them when they are having to work while they're infected? So, the stubborn-headed group of men are gonna work anyway, and it's part of their culture to not be lazy, and it's part of their upbringing to just rough through it. So what are some ways that we can help them to lower the risk or mitigate risks in the workplace? And then
I think I'm going to ask you to just pause there for a minute and let's see if we
Okay.
can get some input. I mean, this really illustrates where we're at right now with COVID communications. And you can shout from the mountaintops, here's what the CDC says about what you should do if you've been exposed, and here's what you should do if you have symptoms. But if you're the provider for a family that depends on you and you feel that you cannot miss work because it's going to put you way behind in terms of much needed salary or other logistical concerns that you just really are salient and most important in your life, it doesn't really matter what health authorities are going to say in this kind of context. So how can those of us who are trying to communicate COVID 2.0 do something to help mitigate this at the same time without undermining the trust, which is so important to rebuild between ourselves and our public? So I'm going to turn now and ask if some of the members of our hub team want to weigh in, but there's opportunities for others to participate as well. Dr. Katie Case, health literacy expert, what are some of your thoughts?
Well, I think this is a great case. Thank you, Joaquin. But I think it brings up a lot of structural issues and barriers that, as you noted, that simply saying like, this is what you should do, you should stay at home, isn't sufficient, and it might kind of lose that communication with them because it's like, okay, well, I know I should stay at home, but that's not possible. So one thing, using the skills is kind of validating their concerns, saying, I hear what you're saying. Ideally, you should stay home if you can, and then provide alternatives as well. Say like, okay, if you are going to go out, maybe talk about, the wearing a mask and the importance of, staying away from other people. If you could potentially get them sick. Also, I think one thing that might be really important is to talk about really worrisome signs, I guess, like how if you are getting to the point where you really do need to go to the ER, or also things as well as potential treatment options that you have right now, like Paxlovid and things like that. So I think, trying to meet them where they're at and understand that obviously staying home is the best policy, but and then also talk about how they can mitigate spread within their family as well.
Thank you for those thoughts. I know we have some other participants here. Melanie Stone, health literacy maven from Health Confianza team. What would you like to add? It's an awkward situation, right? Because it's kind of a scenario in which if you want to maintain your alliance with your patient, and your patient's saying, listen, I know what you said to do, but I can't do like what you said. Then how do you acknowledge that, but still go on with the cards you're dealt and try to make things better somehow?
Well, I think this really goes back to what you said at the beginning of the presentation about health literacy being a force for health equity, and the fact that organizations as systems really play a key role, because it is hard for the individual who isn't empowered to go against what their work life is saying that must happen. So really the change needs to come from the organizations themselves. And, organizational health literacy is finally being recognized by our federal government as a key factor in promoting health equity. So I would encourage us all in our various roles to help bring about that organizational health literacy change, whether it's the policies, the practices, the environment that the employees and their clients are working in, the basic communication skills, the navigation, the cultural and language aspect, all of those big systems changes is really what we need to see start to happen.
And health professionals have a role to play there, right? I'm seeing Dr. Campbell in front of me on the camera here. Sorry to take you by surprise, but I'd just like to invite you to weigh in here as someone who does wear your physician hat and speaks a lot to the public in influential ways. How would you bring those skills to bear on this kind of situation?
Well, the first thing that came to my mind was the use of someone's influence or leverage to help perhaps change things, as Melanie was talking about, in an organizational way. Now, outside my work as a physician, I have recently been appointed to the ethics board for the city of San Antonio. And, my thought is, if people are really being inhibited from taking off because of their companies, whether it be, say, the city or the county as an employer, or someone that contracts with someone like that, I could bring that up and maybe have some influence on how our governmental institutions might handle a situation like that. They could be good role models to make sure that employees are encouraged to go home and to rest when they have COVID or any other illness, and also put leverage on their contractors, perhaps, to do that sort of thing. So that just seemed like a means of influencing institutional behavior that it is much more ethical and moral.
Thank you for that. So influencing institutional behavior is kind of a top-down approach, but there's always a bottom-up approach as well, right? So what would be a bottom-up approach? And actually, I want to see if I can come back to Joaquin Abrego, our community health worker who brought this case to us. What are some community organizing grassroots ways of affecting this kind of situation?
Well, and so some of the conversation that I had with the men was, have you been vaccinated? Are you open to taking medicine? And a lot of the conversation was, well, my son or like my daughter convinced me to get the vaccine, and I'll do anything for my family. And so there was a leverage with family and family influence, asking them to take in consideration that that they care for, that they go to work for their family, they go to work to provide for their family, their community, and they are a member of a group of people who are trying to be supportive for each other. So in that same energy, right? Like we also want to maintain our wellness, so that way we can maintain the future for our family, and so kind of using that leverage to build community around wanting them to be healthy, wanting them to take take that initiative to want to be healthier, and also not to spread it anymore, because what ended up, but who knows how the some of that circle of people would left that camp when they went home and may still have some COVID, and so we want them to all be very, very careful.
Right. So focusing on the downstream consequences, on the individual and family group level, somebody who's not taking precautions because of their work could also bring the infection home and harm the abuela or the newborn baby. And then from the top-down perspective, businesses who understand better, what actually happens when they have these kinds of policies, can see that they could get to the point where they're really shutting down their whole business and harming their business because of workforce issues if everybody goes out sick. And so being able to talk to different people from different angles is critical. Yes, I hear somebody speaking up. Go ahead.
Dr. Berggren, Cesar Garcia had a question, I see.
Thank you.
Thank you.
Yes, Dr. Garcia.
Well, I'm a primary care doctor, right? So I see this every day. And one of the things that helps me as an individual provider is to go in with the game plan. So basically, I already have an agenda that I want to make sure that I cover. And of course, I'm going to try to make it culturally sensitive and low health literacy. But one of them would be that you should probably, like in every case, like about the reinforcing the mask and how you could be contagious and follow-up. So it's good for me to have that game plan going in, and then asking them to teach back to tell me, okay, what did I just tell you? And so it's really, I actually write it down to make sure I don't miss it. So that helps me.
That's wonderful to get your insight from the trenches and the real world. And, that is a mindful practice, right? To set an intention before you go out to your day or in to see a patient, and then bring yourself back to the intention to make sure that you covered it. And thank you for integrating the message about teach back as well. Wonderful. Let's see.
Can I ask Dr. Garcia a question that has to do with communication?
Please.
We worked together for many years at UT Health, and Dr. Garcia has incredible language skills, which I don't have. And I'm wondering if the same kind of information that he just mentioned to patients and the teach back, how much he thinks that's affected by language barriers, trying to get that across to a non-English speaking patient in when you speak fluent Spanish versus when you do not.
Yeah, no, I mean, it's something that it does make a difference. When you speak in the native language, that makes the teach back much easier. And I get a lot of patients that they give me that information, like they feel very reassured and they feel safe and blah, blah, blah. But the truth is that we still have to, again, simplify it. That's why I feel like the game plan is so helpful, because even if you have a translator, if you know that this is what you want to cover and then have them repeat it through the translator, I still think you can make a huge impact, even if your native language is not Spanish.
Thank you for that. And I think we'll all think more carefully about our game plan before we step into a patient room again. It's true that you step in that room without a game plan and there's going to be 551 issues that get brought up by a patient that day, and your issues might get shoved to the bottom unless you are intentional about bringing them back. And in the context of a pandemic, it's so important. Well, I'm very grateful to all of you who are spontaneously participating here. And I just want to remind you that you guys have great cases too. And I'm thankful to Joaquin Abrego for bringing us this real world scenario that he was a part of talking to a group of men who work closely together in a mechanic shop, and how COVID just ripped through their little group. But you all, the rest of you have scenarios as well. And it's by examining these scenarios thoughtfully together that we get to the 2.0 level with our COVID communication. So please take a look at that link that we've put in the chat. Carly just put it back at 12:57. If you want to present a case at any one of our upcoming COVID-19 echo sessions, you can go to that link and fill out a very simple red cap survey. And we appreciate it so much. And remember that we're incentivizing you all. If you come to 8 or more of our sessions, submit a case, fill out our forms. You not only get the lapel pin, you also get public recognition as a Health Confianza champion on our website. Your site of practice gets public acknowledgement, and we'll send you all the swag we can find, including posters for your clinic. With that, I see that it's 12:58, and I'm going to turn the microphone back over to our hub team, Dr. Raquel Romero. Thanks again, Dr. Garcia and Dr. Campbell.
I'm going to be, thank you so much, Dr. Berggren, and I'm going to echo Dr. Berggren's words. Please bring cases. We would like to hear more about those experiences while taking care of your patients. Thank you, Dr. Garcia, Dr. Campbell, and also Dr. Stone, and Joaquin to bring the case today. And be part of this team, the Confianza Team Champion. Please, we invite you to come for our next session. These sessions are normally every 2 weeks on Fridays, but that particular session next is going to be August the 29th. It's going to be a Monday. It's the only session that we have on Monday. So please check your calendar and please try to attend our sessions. To learn the CME and CNE credits, our information in the chat. We would like to please complete the feedback survey. That's very, very important for us. And I will see you in our next session. Until then, please take care and thank you for your time today.
And I just wanted to add that session on the 29th is about outpatient management of COVID-19. Very timely because we still have lots and lots of people many of them close to us, that are still getting sick with COVID and needing our advice. So this will be an up-to-the-minute review of what we know about managing COVID-19 outpatient from Dr. Jason Bowling, infectious disease specialist here at UT Health. Thank you so much.
Thank you, Dr. Berggren. And please mark your calendar, and I'll see you next time.